health and addiction services. I want to say, first of all, thank you for taking some time out of your afternoon to hear a little bit about the governor's proposals as they relate to mental health and addiction services for the next 2-year budget cycle. We have approximately 370 folks who have registered for this event, and if time permits at the end of the webinar, I'm happy to take questions. So you can type your question in through the webinar portal, and I will get through as many of those as I can. But can't make any promises depending on the number of questions that do arise. Okay. I wanted to sort of establish context for this budget by referring to a quote from the governor during his recent inaugural address. He said that every Ohioan deserves a chance and an equal opportunity to achieve their God-given potential, and that's the Ohio we're rebuilding for everyone. And I think that that general theme is very salient to some of the transformation and investment that we anticipate for our system in the next 2 years. Just as a point of reference, the governor has 4 major pillars in his budget proposal for the 16-17 operating budget, and you can see those arrayed here on this slide. Our department fits in most closely to the final bullet to create opportunities for all Ohioans, fight poverty, improve health care. And at the end of this presentation, there are some links to additional budget documents. The Office of Health Transformation, of which our department is a partner, has an extensive series of white papers related to different health and human services initiatives, and there's one specific to our system. I would direct you there as an excellent reference to really health and human services investments across the enterprise for this next 2-year period. I want to start first by talking about Medicaid, and obviously this is a significant part of our behavioral health system in Ohio. What we're seeking to do this year is really build upon the progress of the last 2 biennia. The first year of Governor Kasich's administration, the first budget period rather, we elevated the Medicaid match responsibility from the ATOM board to help create, I think, more consistent access across all communities as Medicaid grows going forward. The second 2-year budget actually extended Medicaid eligibility up to 138% of poverty, and I want to thank you again for all of the tremendous advocacy efforts put forth on behalf of Ohioans who need health care. To date, we have enrolled almost 500,000 individuals, and we are very pleased with the success stories that we hear every day. This slide on slide number 5 shows that Medicaid has had a tremendous impact on our system. And the Ohio Department of Medicaid spending that is shown here in the green represents spending for behavioral health care inclusive of our community system as well as inpatient psychiatric care funded through Medicaid and psychotropic and other mental health medications and some other ancillary services. You can see the blue on the bottom represents our funding within our department for non-Medicaid purposes in recent years to help support the recovery-oriented system of care around the state and really wrap around the clinical care that's afforded through Medicaid. We remain diligent, though, in thinking about further improvements that we could make in order to assist individuals who are served in our system and enrolled in Medicaid. We know, based on data from the Ohio Department of Medicaid, that a relatively small number of individuals served in our system account for a significant cost. And you've heard a lot about hotspots within this administration, and I think we want to continue to focus on connecting those individuals who have the greatest degree of acuity with benefits and with services that are going to help them progress in their recovery and do as well clinically as possible. So we have been working with Medicaid over the last 6 or 8 months to talk about what sort of reform would make the next logical steps for Ohio's community system. And we've got a few things I want to highlight here in these next few slides. First of all, we will be working with the Department of Medicaid and the field to update billing codes to align with national standards in 2 specific services by this coming July, med-somatic and pharmacological management. And we've been talking about the need to do this for quite some time, and we've identified this July as when we anticipate the implementation will occur. We also want to redefine the benefit package so that we can, in a budget-neutral way, put more emphasis on individuals who have the highest degree of acute need. And we've been talking with Medicaid, and they've committed to assist us in altering or transforming our benefit package to include the services that you see listed on slide number 8. And you can see ACT and IHBT, I mean, those have been on our list of goals for probably at least a dozen years for Ohio Medicaid. High fidelity wraparound for kids, peer support, supportive employment is extremely important, and also residential services for individuals who are living with substance use disorders. Because we're approaching this in a cost-neutral manner, we anticipate that we will disaggregate the existing CPST benefit and be more discreet in how we're defining the different elements of service that are today contained within that relatively broad benefit. And in order to help ensure that this is cost-neutral, we want to establish a standardized assessment that qualified provider organizations around the state can use to help determine whether the individual who is presenting for treatment is eligible for these additional services that we plan to add. In addition to transforming the benefit, which we would anticipate would happen about next January or so, we also want to think about care coordination and how we could work in a managed care environment to better enhance coordination. In the month of March, just 4 weeks from now, we will be kicking off a stakeholder process whereby we will seek input from our field and other interested parties, not on the benefit itself, because I think we've had extensive discussions about the kind of benefits we want to offer in the past, but rather the vehicle by which we could integrate in a managed care environment. Is that a single behavioral health provider or managed care plan? Is that multiple plans that also provide physical health care, et cetera? Obviously, there are many different vehicles underway in different states, and we have undertaken some research here. We've talked to some folks informally, but before we make any final decisions on an approach that would be best for Ohio, we want to engage our stakeholders in a formal process. And so look forward to more information on that, and that will help inform decisions that we would anticipate implementing toward the end of this biennium. I want to change gears now and talk about some targeted investments within the non-Medicaid portion of our strategy for the next 2 years. We want to continue thematically a lot of what you heard from us in the past 4 years, really trying to eliminate silos that might have built up, for different regulatory or bureaucratic reasons over time, that help prevent individuals from connecting with the sort of care they need at the place and time that they need it. And we also are trying to go upstream and think about the root causes that are driving some of the challenges in our system. And you can see that thematically in the next few slides I'll be sharing. There are 4 pillars, I think, or 4 themes where we want to make some targeted investments. And I'm just going to go through those here in the next number of slides. The first one is focusing on support for children and families. And in that arena, we are working as part of a broader administration initiative around early childhood wellness and improvement of outcomes. The governor and the administration have supported a proposal that would allow us to invest $5 million per year in early childhood mental health consultation. We would undertake this through a contracted network of providers that could render some technical assistance regionally when a child, let's say, begins to exhibit some maybe overly aggressive behaviors within a child care setting. The teacher doesn't know what to do. Maybe the parents are unsure of some strategies that they could undertake at home to help mitigate further challenges with this child's behavior and help facilitate a referral to treatment in the event that that's necessary. So we're very excited about this, and this builds on some work that we have underway currently at a much broader scale. We also want to continue support for strong family safe communities. You may recall that just about 2 years ago, the governor authorized the use of one-time $5 million for our department and the Department of Developmental Disabilities to co-facilitate so that we could infuse some dollars into communities where there was a some sort of gap, and families maybe were struggling at the verge of crisis because they have a young person in their care who has a serious emotional disorder or a developmental disability or both that is putting themselves or others within the household at risk. And what we want to do here is kind of shore up areas where the community has indicated that a little infusion of resource would really go a long way in terms of support for their continuum. We had $5 million in one-time funds in the last biennium. We are recommending appropriation of $3 million per year, which is actually a $1 million increase for the overall program. We're very pleased about that. The next one I wanted to highlight is some targeted resource for prevention activities. And I say targeted because the area where we want to focus most, if not all of these resources, are some evidence-based programming for children who have parents who are currently or have been incarcerated related to perhaps offenses related to drug addiction. And we know that the outcomes for these young people oftentimes are very challenged just because they have a parent who is incarcerated and or who has been, and we want to really sort of go upstream and place some resources in the hands of communities to help improve the trajectory for these young people as they work with their parents to kind of rebuild the family after the incarceration. We also want to continue to make progress around one of the governor's key initiatives within the last year, the Start Talking Prevention campaign. And so you'll continue to hear focus on that. If you missed the news release a couple of weeks ago, we're going to put specific emphasis in this coming year on partnerships with businesses. That not only lets us connect with more parents around the state, but also helps businesses be thoughtful about drug-free workplace practices and helping to intervene with an employee who might be at risk or might need some intervention himself or herself because of some drug use. I want to change to the second thematic area in our budget now, and that is saving lives. Every life is important, certainly, and we've got a couple of investments that help to underscore this. First of all, we are very excited that the governor's recommending $1 million per year to help us augment suicide prevention efforts around the state. You'll be hearing more about specific strategies there, but I think that this is something that is a risk to all communities, and we're very excited for the support on this front. We're going to continue as a department to emphasize trauma-informed care and the importance of really being able to engage people in the most sensitive manner possible, not just within our field, but within systems that touch the same individuals and communities. So, for example, the court systems, child welfare, et cetera. And we will continue our work with the National Center for Trauma-Informed Care and the local infrastructure we've begun to build out on this subject. Expect to be hearing more from us on that front as well. We are pleased that we are going to be able to recommend $500,000 per year to extend access to naloxone to family and friends and actually individuals themselves around the state who may be addicted to opiates and are at risk of overdose. We want everyone to be connected with treatment, but we recognize that some people are not at this juncture. And we also recognize that relapse is possible as a part of recovery. And we really want to make sure that if we have the ability to assist in saving a life, we're doing so. So we'll be working with the ATOM boards and others to discern a distribution approach for these resources, but we really want to build on logical points of distribution that are underway today folks involved with Project Dawn, whether it's law enforcement or other first responders, public health departments, etc. So very excited about that. And I'd also like to take a moment to thank former Director Orman Hall, who has recently retired from our department, but has been a longtime champion of improving access to naloxone for individuals around our state, and he advocated quite significantly on this subject before he retired in the fall. Want to change to the third topic of investment at this point, and that's related to criminal justice. We have a number of strategies under this general umbrella, but the largest one, and the one where I'd like to spend a few moments today, is on our Recovery Services partnership with the Ohio Department of Rehabilitation and Corrections. You'll see on this slide that the current state in Ohio, we have more than 50,000 individuals who are incarcerated within DRC's prisons, and the vast majority of these have some sort of history related to addiction. Everyone is assessed when they come to a DRC institution, and almost 30,000 individuals have a notable treatment need, but the current resources available within the DRC budget mean that only a small percentage of these folks actually are able to connect with treatment while they're incarcerated. We also know, though, that connection with treatment is very important as it relates to low recidivism. Ohio actually leads the nation in its overall recidivism rate. The national average is close to 50%. It's 49.7 or 49.8%, and in Ohio it's 27%. So I think Gary Moore has made significant progress in reducing overall recidivism, but people who actually connect with addiction treatment while incarcerated in Ohio's prisons have a recidivism rate of only 10.4%. So we know that treatment works, and we know that our ability to connect more individuals with treatment means that fewer folks will be coming back to prison. So we have been encouraged as a cabinet to think very broadly and creatively about how we might be able to help each other. And over the last 6 months or so, Gary Moore and I, in concert with our clinical leadership teams, have developed a strategy that the governor is supporting for this budget period. We want to partner together in order to build more recovery support services within the institutions, and then also help to keep recidivism rates as low as possible by making a concurrent community investment for these same folks as well. We want to make sure that folks are connected with Medicaid as they're leaving prison. I think many of you are aware that Medicaid is prohibited federally from providing reimbursement in an incarcerate setting. So recovery services within the institution are funded with state dollars only, but we want to make sure that people have access to Medicaid as soon as they leave. At this point, DRC has been working very effectively with OhioMHAS to develop processes by which individuals, as they transition back to the community, are, to the extent they're eligible, are enrolled in Medicaid. And they leave with a card so that they can actually have reimbursement for their clinical services as soon as they come back to the community. And at this point, all of the female prisons have been connected with this new Medicaid enrollment process. And data show that between 90 and 95% of those women are actually eligible for and are enrolled in Medicaid upon their release. So I think that's fantastic from a continuity of care perspective. However, there are, so we will continue to do that, but there are other recovery supports that Medicaid doesn't fund, and we want to make sure that things like sober housing, peer support, employment services are available as well to help, again, keep the recidivism rate low and help to reintegrate these folks into our communities. So specifically, what we are proposing to do in terms of the partnership with Rehab and Corrections is to transfer $12.5 million from Gary's existing budget into our budget. And that appropriation supports approximately 120 staff who are currently providing recovery services for addiction treatment within the walls of the DRC institution. So effective July 1st of this year, those employees will be shifted over to our payroll. They will continue to provide services in the same institutions where they are today. It should be a relatively seamless process for them, but they will become part of our mental health and addiction services team. From there, we have additional appropriation that the governor is supporting for both fiscal 16 and 17 to augment the number of individuals who are rendering services within the state prisons to connect more inmates with addiction treatment. This is going to be a significant staff increase, and we are very excited about our ability to reach more offenders prior to them leaving prison. And the key area of focus are going to be nonviolent offenders who are serving up to 18 months of a sentence. And oftentimes, these folks do not have access to treatment today. Assessment occurs when they first come into the institution, and treatment today isn't available until they move out to a parent institution and are closer to their release. And there are waiting lists in many places for treatment, and that's what we're seeking to augment. We've been looking at the clinical plan that DRC has in place, and we feel that it is quite sound. They're using evidence-based practices, cognitive behavioral therapy specifically, and we want to continue to grow that within the institution and help to ensure that upon transition, those same individuals are connected to a similar treatment in the community. So that brings me to the next piece, the expansion of outpatient recovery support for people once they are released from DRC's custody. We know that about 50% of these individuals who are released are under the purview of the Adult Parole Authority. And so treatment may be stipulated as a part of their release plan. The other 50% go out without any supervision whatsoever, and they may or may not connect with treatment because of capacity issues in the community or just general challenge connecting with service. So we want to make sure that treatment is available and recovery supports are available for these folks as we go forward. Said quite a bit about that. I would like to focus on a couple of other criminal justice related items that are included in our budget. You may recall that in this current biennium, we had $2.5 million appropriated in each year for the addiction treatment program, currently known as the Addiction Treatment Pilot Program, where we support 5 different drug courts around the state to connect enrolled individuals on that specialty docket with services and supports and clinical treatment necessary to help ensure that their participation in the drug court is as successful as possible. We are proposing to continue funding in both 16 and 17 at $2.5 million. And given the continued impact of Medicaid in our system as a payer for clinical services, we're hoping, pursuant to the evaluation results that we will receive later this year, that we can actually use the same dollar amount to extend to at least a couple of additional courts around the state, because Medicaid is a bigger payer than we had anticipated for the treatment services when we initiated this 2 years ago. We also have $1 million per year that we're proposing to invest in administrative costs related to specialty dockets, and these are courts that are certified through the Ohio Supreme Court as specialty dockets. You may recall that we have $4.4 million appropriated for this purpose in this current fiscal year. As courts came forward to request these resources, we were able to discern that just over $1 million of the 4.4 has been used to actually expand capacity with these courts. And that's really what we want to focus on going forward, is expanded capacity. So thus the rationale for the appropriation change compared to fiscal 15. We also support and have supported for many years 10 community forensic centers around the state. We are proposing an augmentation to our payments for those centers of about $350,000 annually, and this will help cover the costs associated with mileage and caseload and other factors of these centers when evaluations are necessary this is the go-to group of folks, and so we want to make sure that we're helping to defray some of their rising costs. Similarly, we have a lot of interaction within our mental health system and our hospital system with probate courts. And we have a line item in our budget that has helped to defray probate court costs as it relates to individuals who become patients in our hospital and need to go through probate proceedings. We are proposing an addition of $500,000 each year for probate courts. Again, both of these, they're not complete coverage of all costs, but we think that these two investments will help to defray sort of cost creep that has occurred over time, and also note that we see these two, both probate and community forensic centers, as important parts of our mental health system. We also have a proposal included in this budget to develop different strategies around the state through some demonstrations that will help ensure access to our 6 state hospitals. We have $3 million set aside. Again, this is one of those ideas where you kind of go upstream and make an investment that helps ensure access challenges no longer exist. We've had a significant increase in admissions in our hospitals in the last 4 years, and we've been looking at some of the drivers to those increases on a hospital-specific basis. And just to offer an example here, our hospital in Athens has 88 beds and serves virtually all of the Appalachian area of Ohio. And Athens has the highest penetration of jail transfers among any of our 6 hospitals. And, thinking about that, people are transferred from the jail into our inpatient setting because there is a lack of mental health services in some of the more rural jails. And so the thinking here is that if we can invest some resources with the jail to have some basic mental health services available, that might help mitigate crisis situations from occurring and thus mitigate the need for an admission in our hospital setting. Another example where we are trying to go upstream and help assure access for folks who need inpatient services is in the area of community-based competency restoration. In some areas of the state, we have a pretty significant penetration of folks who come into the hospital because the judge has ordered competency restoration. And there aren't any community opportunities to have that restoration done locally and in a community setting. So an infusion of resources for that purpose would actually help continue access to hospital beds for others who might need it for more of an emergent reason. We also want to continue what I believe is a very successful program in the last 2 years, our community innovations partnerships with the Adam boards and county jails. We have been able to assist quite a number of counties in the last 2 years. The communities come to us and say this is what they would like in terms of an investment and for what purpose, and we've been able to do some grants. I think this year we want to be a little more focused on helping individuals connect with Medicaid upon release from the jail. You'll be hearing more about that, but I think, again, this is a very valued partnership, and this is an area where there are gaps in many parts of the state, and we want to try to be helpful there. Next, I want to shift to the 4th theme, and that is housing and employment as recovery supports. The first area here relates to housing in our licensed group homes of 16 beds or less. The Residential State Supplement Program is a subsidy for individuals, many of whom live with serious and persistent mental illness, to help cover the costs of their housing and their care in these group homes. We're proposing that we continue funding for this program at $15 million a year, which retains the MBR investment of $7.5 million. We effectively doubled our investment in this program this year, and we want to continue that going forward. We also have $2.5 million proposed to support recovery housing around Ohio. You are aware that we had a very significant investment this year, $5 million in GRF and $5 million in our community capital budget to help establish recovery residences around the state. And through the consolidated efforts of those two grant-making processes, we have been able to serve at a minimum 660 folks per year, assuming that someone who moves into a recovery residence actually stays there for the entire year's time. And we know that some folks move in and out if they're ready to go on to other settings. But we're pleased to be able to offer $2.5 million this year. Within the last few months, we've established Ohio Recovery Housing, which is an organization that is going to build a network of quality improvement and technical assistance around these recovery residences, both those that are funded by the state and those that are privately funded. And we will look to that organization as well as other data going forward to kind of inform where we make the investment and how we make the investment in recovery housing as this resource evolves within our state system of care. We're going to continue support for Recovery Requires a Community. You may recall that this is an investment that we made 2 years ago in concert with Ohio Medicaid, where we are assisting to transition more individuals with mental illness from nursing homes into community settings. And we look forward to continued progress in that area as well. There is a housing white paper that the Office of Health Transformation has on their website that talks about quite a host of additional initiatives related to housing. And anyone who knows me knows that we spend a lot of time on housing-related items, and we are partnered to many of the initiatives that are described in the white paper. And I would just recommend that you take a look at the information included there. We're really excited about the focus this year on that the administration has on housing. And then finally, rounding out this category, I wanted to note that we're proposing $1 million investment around workforce and employment. The governor probably, at least once every couple of weeks tells me, well, I've talked to so-and-so employer and he can't find anyone to pass a drug test, in whatever, wide variety of trades, et cetera. And so this is very much on his radar and very much on the radar of the Ohio Chamber and other interested parties. And we're proposing an initiative whereby we will be able to help connect employers with improved access to thinking around drug-free workplace policies, second chance kind of provisions for folks who may not be successful in passing a drug screen the first time, but with some intervention and or education as necessary, they might be able to be open to considering that person for employment again down the road. We also know at the same time that there are a host of folks, whether they're living in recovery housing or they're just in recovery throughout Ohio, who are successful in their recovery. They are able to pass a drug screen at any time, and they need jobs. And so part of this resource is going to be helping connect those potential employees to the employers who are saying that they can't find qualified and drug-free workers. This slide contains a listing of our appropriations. The first half of the slide is general revenue funds, and the last part of the slide is all funds, which includes our Rotary resources as well as federal sources like the block grants and other competitively awarded grants. Let's see. So there is more information about line item specific detail on the Office of Budget and Management's website. They have a drop-down box there where you can just search for our agency, and there's a write-up from their perspective on our funding circumstance. I haven't talked about hospitals yet, and I want to take just a moment to mention the important role of our 6 state psychiatric hospitals. We have just under 1,200 beds in Ohio that are available to individuals who have an inpatient need. And as I mentioned earlier in this presentation, our admissions have increased significantly in the last 4 years. And so this shows you that last fiscal year we had more than 7,700 admissions. Our funding for the hospitals is proposed to increase. There is a GRF funding increase of approximately $10 million, but I want to make sure that I'm clarifying that the all funds appropriation with respect to the hospitals is about $5 million. We've had third-party revenue from Medicare decrease in the last year or so, and going forward, we anticipate that that revenue stream from third-party insurance payments is going to be about $5 million less per year than it's been in the most recent few years. And so taking that into account, we have undertaken some austerity planning within the hospitals. We have gone with a utility management company to help lower utility bills. We have trimmed our admin staff, taken other efforts, but we still have rising costs. With increased number of folks coming into our hospitals as new admits, we have higher costs for medication. We have infrastructure costs and things like food and staffing and such that we need to manage. And so all told, our requested increase is $5 million, but in GRF you'll see that bear out as approximately $10 million. And I would note, as a former budget analyst, that this GRF appropriation is actually less than what we had budgeted in state fiscal year 11 when we had 2,000 fewer admissions. So we are trying to be as judicious as possible in making this request. Also want to touch on another line item that we created in the consolidation of mental health and ODATIS about 18 months ago. Our 421 line item is called the Continuum of Care. We have made a few adjustments in this line, including the assumption of $2.5 million for alcohol and drug hotspots programming that had previously been funded in the 507 line item this year to be moved into the Continuum of Care line item. We will be talking with the ADAM board as far as the disposition of these resources going forward, but I do want to make sure folks are aware that the appropriation in this line is approximately $5.6 million less than what it is in this current fiscal year. There's a lot of change underway within our financing system, and I've talked, a number of times about the impact of Medicaid, which is really bearing out in different ways in different places across the state. This is just one example on slide 24. This shows the number of prescriptions that we have filled with a portion of that line item in the past several years. The former community medication subsidy line item was melded into line item 421 last fiscal year. And you can see that starting in Q2, which is just after Medicaid expanded in Ohio, the number of prescriptions that were filled using resources from this line has dropped off substantially. And intuitively that makes sense, because as people get connected with Medicaid, the need to use GRF-only funds to fill prescriptions is no longer as prominent as it had been prior to Medicaid expansion. So this is just one example of some of the changing financing that's underway within our system. I want to highlight for you a few language changes that we've proposed. The first one here is at the request of SAMHSA. When we elevated Medicaid to the state level and transferred the appropriation over to the Ohio Department of Medicaid in fiscal year 13, at that point, SAMHSA no longer wanted to include the state's Medicaid spending as a part of our maintenance of effort for the substance abuse prevention and treatment block grant. This did not make a lot of sense to us at this department because the resources were still being used in the same way, and we're actually supporting more services for individuals than had been the case previously. So what we're doing in order to address SAMHSA's concern here is that for the purpose of the block grant maintenance of effort requirements, both Director McCarthy from Medicaid and I from this department are being designated as dual leads, as single state authorities for substance abuse prevention and treatment. So this is a technical change that SAMHSA has requested so that they are able to count the Medicaid as match. or as maintenance of effort, rather. The second change, not nearly as detailed as the one I just went through, we are aligning our state law to match new HIPAA standards as far as community access to records of individuals in state hospitals who've been deceased at least 50 years. Again, we do not anticipate this will cause any controversy. This is to align with recent changes to the HIPAA requirements. And it would actually help someone who's maybe searching for genealogy records from their family from long ago. Excuse me. We also have language sort of streamlining some of our licensure and certification processes. Currently, we have the ability, if a child residential provider is placed into a probationary status, our department can suspend admissions to that provider. That is not the case for other provider groups, including inpatient psychiatric units or others. And in the last year, we've had a few circumstances where, for health and safety reasons, it would have been helpful for us to have that ability to limit admissions when the provider is in a probationary status. And so we're seeking to extend that option to extend to other provider types as well. In this budget, we are planning to rename the former Office of Support Services as the Ohio Pharmacy Services. This is our operation that provides pharmacy services to all of Ohio's prisons, as well as many community behavioral health centers and a growing number of jails around the state. So again, just to be more explicit about the purpose of that office. And we are also proposing to remove the requirement that our department report to the legislature on former House Bill 484 funds. These are resources that I believe were eliminated in fiscal year 2000 that enabled women who had custody of their children transferred to child welfare to connect with treatment in order to try to reestablish the family as a single unit as soon as possible. We haven't had the resources for many years, and so this eliminates the need to report on the use of those resources. We are also seeking to not make fundamental change to the continuum of care language that was altered in the MBR, but to reorganize some aspects of that language. We want to group all the recovery services to be listed together, as an example. And we also want to clarify that recovery services do not have to be certified by the department in order for boards to reimburse. To give you an example of this, recovery residences, which are newly emerging as resources in Ohio, are not able to be directly funded by boards at this point because the Department of Mental Health and Addiction Services does not certify recovery residences. So we want to make sure that the ADAM boards have an ability to reimburse for these sorts of services if they elect to do so. And we would retain the ability to ensure quality measures regardless of whether or not we certify. Speaking of the continuum of care language, many of you are aware that the changes that were introduced in the MBR become effective in September of 2016, and we will be kicking off a process here very shortly to talk about how specifically we will work together as a system to implement that language. So look for more information on that in the near term. Just want to make a note about central office. We consolidated mental health and ODADIS about 19 months ago now, and when we did that, we were able to reduce admin spending by $1.5 million a year, and we transferred that into a service line item so that we could really demonstrate that we were trying to be as judicious as possible with our admin in order to increase access to services. And specifically, we funded the partnerships with the ADAM boards and the county jails with those dollars. We are continuing to try to streamline our admin operations, and we will be reducing our administrative budget by $1 million in GRF this year, or this next year, and carrying that forward into fiscal 17 as well. And we're also working on a variety of shared services collaborations with other state agencies, and to the extent that there are direct community benefits, I know probably some people on the call are actually party to those discussions, and we are excited to be able to try to be as lean as possible from an admin perspective in order to help support what's happening in the field. I promised that we'd have more information about the budget. We have a website page on our website that has some budget-specific information, and we will be continuing to augment that as we go through the process. We've established an email box where you can send questions, and you can see that address here, and we'll use that to help you direct feedback if that's appropriate, or share information more broadly depending on what the question is. The OHT website is listed here, and there's, if you go over to the right-hand side, there's a lot of budget information through a link, and you can get access to all the OHT white papers. And then finally, the governor's office has a budget website that talks about the broader initiatives that are being proposed to help transform Ohio. So with that, if you're not already following us on all manner of social media, this is your opportunity. You can go to mha.ohio.gov and sign up for our listserv, and we will look forward to connecting with you in that way as well. Let's see, we have, trying to see here, questions. We've got quite, oh my goodness, we've got quite a number of questions so far. So let me scroll back up to the top here. And the first one is from, I can't see who it's from Kristen. I can't see where she's from, but it says, can you give me any more specifics on Start Talking in terms of the projects that were started this fiscal year? We have, in this year, we have grant-funded $1.5 million in partnership with the Governor's Office of Faith-Based Initiatives and the Office of the First Lady to fund 22 different projects around Ohio focused on evidence-based prevention practices. Many of these are targeted toward elementary schools, but we allow communities to propose, what they thought would be the most important target audience. We have also been working with the Drug-Free Action Alliance to send biweekly email tips called KNOW, K-N-O-W, that help basically inform parents and other interested adults on how to talk to a young person about the dangers associated with prescription drugs or other kinds of risks that they will encounter during their adolescence, certainly at some point. And we have been able to grow the distribution of that to more than 50,000 individuals at this point, both through direct sign-ups to our website and also through the school districts and others. And we also have the 5 Minutes for Life with the Department of Public Safety, where the uniformed officers go into high school practices, sports practices, and talk about the decisions that individuals, the students are making. They're actually being watched by others because they're considered to be leaders in their school. And we have been able to impact or connect with more than 18,000 young people through that approach in the last year. We just set up a new business component of our Start Talking website, and so I'd encourage you to go to starttalking.ohio.gov and click on Biz and Business Impact Zone, sorry. I always forget what the I stands for. And you can get more information there. Okay. Oh, sorry, this next one says, can you speak up a little bit? This is hard to hear. I apologize. I usually consider myself to be a pretty loud person, but hopefully folks were able to hear most of this. Let's see. It says, Director Plouk. This one, I cannot see who the asker is, but it says, of the $12.5 million transferred from DRC to mental health and addiction services, are some of the dollars going to the field? You mentioned transitioning from DRC to our department working in the institution. I just want to clarify that for a moment. The total appropriation in the new line item to support all of this is about $27.3 million in fiscal 16 and $34.3 million approximately in fiscal year 17. Embedded in those numbers is the transfer from rehab and corrections to us, $12.5 million to support the existing 120 staff. The balance of that is so about $15 million and about $22 million is intended for community investment and the augmentation of staff within the institution. So we are planning a significant increase within the fence as far as the number of treatment providers who would be state staff and serving in that role. But the majority of the new funds, the additional funds beyond the 12.5, will go to community services. We anticipate we will start the staff augmentation within the institutions this coming July, very shortly after we transition these folks over to our payroll, and we hope to be completely staffed by the end of December of this year. We will be working through the process to get the community dollars out into the community, developing the plans, finalizing the plans this spring, and then actually executing that process in the fall so that we would have community dollars available on or about January of 2016. So again, those dollars would go for treatment services to the extent that a person is not, for some reason, Medicaid enrolled or eligible, housing, transitional housing or recovery housing as needed, access to medication-assisted treatment if that is clinically appropriate and needed, and also things like employment services and peer support, et cetera. So look for more information about that. We definitely want folks to be involved in the planning there. Going to the next question, let's see. Can you provide, and I can't see who's asking this either, can you provide a few more details about thoughts or plans for including substance use disorder residential services in the Medicaid behavioral health benefits? We know that in some places in the state there is a shortage of residential capacity. Not everyone needs a residential level of care. I want to start out by saying that. There are many, many, many people who are very successfully treated at an intensive outpatient or outpatient level of care. However, for those who need residential services, we want to make sure that capacity is available. And today, the financing of these residential beds is somewhat chaotic, I guess I'll use in my words, because in some places the discrete services are can be reimbursed by Medicaid depending on the number of individuals who are served in that setting. In some cases, the ADAM boards provide room and board, or there's different factors related to private pay, and we are very excited actually that Medicaid is willing to work with us to see what kind of an approach might make more sense to kind of even out access and even out financing around this, recognizing that Medicaid does not pay room and board. So I think we will want to be engaging the field on this as well, and particularly providers and payers of this service currently who have some ideas about what a logical approach would be. So I don't have a ton of details right now, obviously, but we would like to include that in a benefit package reformation. Let's see. The next one just says, very exciting. Thank you for your passion and work. This is from Paul Quinn from Menominee County. So thank you, Paul. Let's see. The next question, are there any plans to expand eligibility to recovery requires a community? If there are not plans, will there be discussions about how to expand eligibility and utilize more of its funding? For example, eligibility to include consumers currently living in the community. The way that we are financing recovery requires a community, it is, we're financing that by the savings of, that Medicaid is realizing by having individuals move from an institutional setting into a community-based setting. And so I recognize that certainly there is a need to help sort of shore up sustainability plans for people who are already in the community, but sort of in the aggregate and very generally speaking, if we started using these resources to fund any sort of community circumstance, there would quickly be a draining of the resources that are realized, as people are moving from institution into community. So any change that we would consider undertaking in this program, we would certainly need to negotiate that with Ohio Medicaid. I will add, though, that we are using a portion of the savings that have been identified through this program to help fund some quality improvements within our licensed settings, our adult care facilities of 16 beds or less. We think that is, that's oftentimes a place where individuals move after they come from a nursing facility, and that's one example where the quality improvement program that we've developed with Medicaid's blessing to support those facilities is not directly related to an individual moving in there who takes advantage of recovery. So I think, there are some examples now of how we're using these resources to support overall community access, albeit not on a person-specific basis. Not to sound too bureaucratic, so I apologize if that did. I guess short answer, there are no eligibility expansion plans underway there. Let's see. Reading the next one here. It says, please elaborate upon disaggregating CPST service. I think that we will be wanting to have a broader conversation about this with the field, but our ability to reform the Medicaid benefit, to be more attentive to the needs of people with the highest degree of acuity, is contingent on it being cost neutral. That's been a very clear expectation from both the Department of Medicaid and the Office of Health Transformation. And so if you're working within a zero-sum environment, what we've been talking about doing is actually sort of examining the CPST costs that are being covered today for what kinds of services, and parsing some of that out so that we could stand up an ACT benefit. Some people use CPST reimbursement to help cover ACT team costs, but because of the benefit limit for CPST, that's not really a one-to-one ability to match the ACT team expenses. And so that would be an example of if we took apart some of the CPST as an example and made assumptions of how much would be spent for ACT, or in a reformed environment, we wouldn't have enough to continue to do both ACT and CPST for that individual, nor would it be necessary. So we will be having plenty of conversation about this, but that's one example of why we would need to take a look at CPST in the context of any transformation in a zero-sum environment. The next question is, will these slides be made available to us? There's great information here, and I can't keep up. Obviously, I'm talking too fast, so we will be posting the slides, and I think that's a good way to end because we are actually at the end of our time. We didn't get to all of the questions, so I apologize, but I want to remind you that we do have the email address. MHA.ohio.gov.budget is our website, /budget, excuse me, is the website where you can get more information, and we'll be posting additional FAQs and things there as questions come up and are addressed. So thanks for your attention, and I hope this was helpful.